that we won't be broadcasting next week.
Good afternoon and welcome. My name is Alex Hernandez. This is Dr. Craig Stern, President of Pharma Pharmaceutical Consultants and Pro Data Analytics. Last week we talked about medical marijuana, and during that discussion we also mentioned how medical marijuana can be used to kind of wean people off of opiates, right? Opioids. So that inspired the topic today that we're going to talk about opioid abuse and talking about the opioid abuse epidemic. So the truth is, the opioid abuse has become an increasingly large problem in the United States. According to the American Society of Addiction Medicine, in 2012, 259 million prescriptions were written for opioids, and by the numbers, it's enough to give every American a 30-day supply of opiates. And according to a report by CNN in 2014, opioids were involved in 28,647 deaths, which accounts for 60% of U.S. drug overdose deaths. So, Dr. Stern, to try to resolve this epidemic, we're trying to understand what caused it. So, how have pharmaceutical companies, physicians, and patients contributed to this epidemic?
Yeah, that's a very good question, actually, Alex. The problem here is that we have a multifactorial problem. We created it, so let's be clear about that. But the problem is, one, drugs that work, they dull the pain, and in many cases make it bearable for people who have really severe pain, like cancer chemotherapy, things like that, or absolutely horrible bone pain or neuromuscular pain. And they work really well. But that led to physicians who had no limits on how they prescribe. So as a result of that, they prescribed very large amounts. And there's been studies that were published in the New England Journal that identified that physicians, including orthopedists who deal with bone problems, were giving extraordinary amounts of opiates after bone surgery or before in order to try and help the patient deal with it. So we had physicians who had no limits on it. We had patients who were demanding more in order to try and deal with it, because the notion was that no pain is the good thing, any pain is a bad thing. In fact, from a medical standpoint, having a little bit of pain is not a bad thing. And I'm not trying in any way to demean pain in any measure. But clinically, identifying that there's pain and trying to measure it is something that you use clinically in order to identify whether there has been a diminution of pain, whether the problem is getting worse or otherwise. Third, pharmaceutical manufacturers identified this as a ready opportunity in order to address it. And fourth is that it became a standard of care, and about 50% of all prescriptions are written by primary care physicians. So it wasn't just purely orthopedists or specialists. It became part of the standard process of what went on. But having said that, let's put this in context. The context here is the following. We have patients who require pain management. We have patients who are desiring more pain management even if they don't need it, not understanding what the consequences are.
Right.
And then we have people who want it because they are using either legal drugs illegitimately, or they're using illegal drugs illegitimately, and having opiates adds to the particular problem. With regard to physicians and what went on with legal prescribing, about 1 of every 7 patients that was on long-term therapy, meaning therapy for longer than 3 months, continues on these drugs potentially for a year or more. This is extensive for acute care problems.
Right.
And second is the fact that these therapies, if they're used on a chronic basis, meaning long-acting drugs versus short-acting drugs, what we see is that there's a greater use of long-acting, and therefore people stay on it longer versus short-acting drugs. And now people are beginning to use short-acting drugs month after month after month after month, when in fact they were never for that. They were for short-acting drugs and short-acting treatment. So in fact, this isn't just a doctor problem, a patient problem, pharmaceutical manufacturer problem, or otherwise. This is a general problem that's occurred because drugs work, but in fact we've overused them, we've overprescribed them, we frequently are prescribing them in a way that isn't useful.
Right. So numbing the pain just kind of compounded the problem, basically.
Exactly.
Right.
Exactly.
We also know that over time we have recognized the problem. I think it started sometime in maybe the 70s, 80s, where they started noticing the epidemic and noticing people abusing it. And we also know that several measures have been implemented to alleviate the opioid use, which includes restriction. How effective is this restriction?
Well, it has been, and let's put this into context.
Mhm.
We have an opioid epidemic, and what does that mean? What are we talking about?
Right.
When we're talking about that, the opioid epidemic has been defined both by the Centers of Disease Control, the CDC, and others as people who are utilizing the emergency room for pain management, people who are dying because of opioid or prescribed medication,
Mhm.
and third is people who are using these medicines as alternatives, and as a result of that, they're ending up in the hospital, and the diagnosis that is identified is opiate abuse or drug misadventure. So that's what we're measuring, and these are the measures that have created that problem. Now, several states, especially California, Minnesota, New York, have limits on the amount of prescribing that can be done. They also have programs like in California, the CURES program, where opiate prescribing is on a web. Doctors, pharmacists, nurse practitioners, physician assistants can access it legally with appropriate passwords to see, so that if they have some concern about a patient, they can see all the prescriptions that a patient has received from all doctors.
Mhm.
And so in those states where it's been done, the number of prescriptions has fallen. In workers' comp, where there's been a significant impact on it, the number of prescriptions has fallen. And consistent with the number of prescriptions has also been the number of deaths. Not necessarily the number of ER admits,
Mhm.
not necessarily patients going to the hospital with a diagnosis of drug misadventure, opiate abuse, but deaths. So there has been an improvement in that regard. However, the move to put some controls on this to try and limit it, which is essentially saying you can't prescribe too many tablets,
Right.
you have to review the patient multiple times within a 3-month period, etc. Those things have limited it to a degree, and now there's evidence that people are also beginning to use illegal drugs like heroin, and depending on the state, also marijuana in order to use these drugs. Using marijuana may not be the problem issue, but we are moving from legal substance use, legal prescribed substance use,
Mhm.
to illegal drug use. And that becomes a problem because that's a societal issue, while we're talking really about a medical issue when we're talking about ER and death, etc.
Is there a way of restricting that? We know that when we tell the doctors not to prescribe um, as much opiates anymore, or make a judgment on whether the patient really needed it or didn't need it, um, and then we see the patient go from legal to illegal, like in a snap, because they're dependent or for whatever reason. Um, how does one restrict that use, the legal use?
Well, on one level, you have to do the appropriate things to restrict the legal use
Mm-hmm.
and have people educated, which does something to the illegal use.
Right.
And then the illegal use becomes a societal problem that has to be addressed. From the standpoint of education, it's terribly necessary that all physicians, all pharmacists, all nurses receive appropriate training in the appropriate use of medication. So
Mhm.
number one is acute care therapy for short periods of time with limited numbers of tablets in order to solve that. Because if they're still using it after a short period of time, in most cases, the problem should have resolved over a few days. And if they're not, then either there's a medical problem that has gotten worse or hasn't been addressed, or there's other factors that the patient is asking for the medication other than for a clinical use. That's issue one. So education. Number two is limitations on it. Number three is certainly states like Minnesota and California and New York, etc., that have these cures type of lists, so that there is lists of all the people who are getting it, so that professionals can look at those issues to see what somebody is on. And then third is to try and limit it to those areas where they really need it, like cancer chemotherapy, like cancer care and others, where the pain is necessary, end of life issues where you want to keep the person comfortable, those kind of things to address it. Now, with regard to illegal use, if you've done the appropriate educational things, then to some degree, although it's difficult to study this, you have limited some of the illegal use to what goes on. Then you have to deal with the societal problem, and the societal problem is effectively is a supply and demand kind of problem. Where's the supply coming from? How do you deal with the demand? How do you limit that demand? In some cases, there's a financial interest that people have in selling these drugs. You have to figure out how to deal with these societal issues. In general, government efforts to stop the societal issue have been rank failures. And that's across that's apolitical. It goes across presidents of Democrats, Republicans, everybody. Just trying to limit it from a government standpoint has not been the solution.
That goes to education as well.
Education as well as how everyone else does it. Sure.
Is there much focus in the educational format when say a student is going to pharmacy school or medical school? How much education is there in that forum for?
It's limited. In some of the people who went to school more than 10 years ago, you learned about the drugs, you learned about what they were, you learned about difficulties, you learned about adverse drug effects, but there was really no restrictions on it. Today, there's a good deal more restrictions, more education. So the newer practitioners are learning more today than the practitioners of yesterday. However, there's still patient demand and everything for it. So we can attack it on one level, but we have to attack it on all the levels that I've talked about in order to address that. And that's not just purely a problem of how you educate everybody. The CDC and other groups have made a major issue to educate everybody, get all physicians to be aware of what the problems are, educate their patients. And then, of course, with controls, in a simplistic way, you're scaring physicians, you're scaring pharmacists, you're scaring nurses not to overuse, but scare only goes so far as people begin to look for other avenues. So education is certainly that. And it's not just education, it's training. You can't just talk, I can't just talk to you and say, do it this way and you're going to remember it forever. It's training. You do it now, you do it again and again and again and again, because it's training to try and ensure that that happens. And it's education of patients. What are your options? What other things can you do? Is there physical therapy? Is there acupuncture? Are there massaging? Are there other terms? As well as an understanding that in some cases, having some pain is necessary to know whether something is getting better or not. If it's pain that is immeasurable and is something where someone cannot function, they can't undergo the practices of daily living, that's one thing. And certainly you want to address that. Having a little bit of pain, on the other hand, may not necessarily be a bad thing clinically, because it allows you to see when something is resolved. And there are numerical systems and face grimacing systems and otherwise for a clinician to look at to tell, do you really have a problem or don't?
Right. You want to avoid numbing the patient because you want to see if anything else has happened.
Exactly.
Also, how does managing opiates effectively benefit all parties, including the health plan? So, like, if I was a health plan, how would managing this opiate use benefit me?
Well, on one level, being opiate addicted is not a good thing clinically. You
Mhm.
don't have control of your activities, you don't have control of your life because you're dependent on something else and you're dependent on drugs.
Right.
So, on a personal level, that's not necessarily a good thing.
Mhm.
Number two is that clearly it costs. The cost of the drugs, the main drugs that people watch is hydrocodone and acetaminophen, which is one of the cheapest of the opiate pain management drugs.
Mhm.
And as a result of that, this is not entirely a cost issue. Clearly, one can go to tramadol or some of the other drugs, but many of these drugs then become expensive. And it's also been shown that the shift from hydrocodone and acetaminophen to tramadol has not been a good solution because the number of prescriptions of tramadol increased.
Okay.
So it's not just a good solution to move from one product to the other, and that it's just a cost problem. It's not.
Mhm.
What it affects for you is that it influences your daily life. It influences, unfortunately, your sensorium. So even if you don't seem like you're compromised, you may get into motor vehicle accidents or get hurt when you're crossing the street because you don't really sense what's going on around you the same as if you weren't on opiates. It changes your attitude and how you are interacting with other people.
Mhm.
And then, of course, it's an addictive behavior. So it becomes something where it modifies and changes your entire view on your life and what your life is worth. And that also leads to cases where I can take a little bit, I can take more, I can take more, I can take more. And at the end of the day, there's no limits on it. When you do that, then you kill yourself.
Mhm. That's a strange note to go on.
Yeah.
Well, that's all we have for today. We want to remind you to please visit propharmaconsultants.com. Also visit our RxInfoX page. You can find it on our website. We have new videos every Wednesday at 12, but we won't be here next week. So please come back again in 2 weeks from today. Remember to like, share, and subscribe. And also catch up on our previous episodes. We mentioned medical marijuana from last week. We also have several episodes from before that. Also, that's it actually.
Yeah.
All right. Have a great day.